House Bill 78 was the bill that we filed last year, and this BR is very similar. There was a small change that the Department of Insurance wanted to make to ensure that this could be implemented. So we're talking about a psychiatric collaborative care model this morning. And I'll talk a little bit about some of the reasons that we feel this is necessary. We know that Kentuckians are suffering from mental health issues and that they need better and sometimes immediate access to mental health services. And they're oftentimes presenting to their primary care provider with those mental health issues. They don't have ready access to a psychiatrist, and so that's what this would encourage. This also requires that mental health services are covered on par with any other medical treatment as per the Mental Health Parity Act, which we passed a few years ago in alignment with the federal Paul Wellstone and Pete Domenici Mental Health Parity Act of 2008. This proposed psychiatric collaborative care management model will allow for behavioral health care, which is integrated into primary care, and the care will be consistently covered across all health benefit plans. The collaborative care model, Dr. Aslam will talk about why this is a better approach to patient care in a minute, but this is a specific approach that has demonstrated meaningful success for patients. It is a team-centered and evidence-based approach to care that keeps providers accountable for quality, and it integrates care across all providers, patients, their families, and communities. The collaborative care team is led by a primary care provider and includes a behavioral health care manager and a consulting psychiatrist. This would retire the current pay structure, which is a flat rate or a flat fee for each individual service. That is HCPCS code GO 512, and it replaces it with established CPT codes for collaborative care. I won't go through each CPT code unless there are questions, but this current flat rate structure does not account for the varying levels of complexity and intensity required and involved in providing collaborative care and psychiatric services. Just a last couple of notes. Research. This collaborative care model has been carefully researched. It is evidence-based, and it has been piloted and shown that the collaborative care model has proven more cost-effective than treatment as usual, saving $6.50 in U.S. dollars in healthcare costs for every $1 spent treating depression. The proposed change represents a critical step toward creating a more sustainable and equitable framework for federally qualified health centers and rural health clinics to provide high-quality, integrated behavioral health care. And so simply moving away from the flat rate approach will allow for more flexibility and responsiveness to patients who are requiring the services for mental health care. And I would just add that we have seen an explosion in the need for mental health services. You turn on the news every day, and you can see that we are not meeting the needs of patients. Partly this is a workforce issue, but this would extend that workforce and encourage better treatment. So I'm going to hand it over to Dr. Aslam now.
Hi, yeah, good morning. I first want to clarify, at Sterling Health, we don't officially practice a collaborative care model because it's cost prohibitive. We would like to. What we offer is basically integrated healthcare, where we try to integrate behavioral healthcare into primary care, because we know that most people don't just show up at a psychiatrist. They go to their PCP, their primary care provider first. So as Representative Moser alluded to, I'm sure you've noticed, if you watch the news, the people are not well. We have a mental health crisis among the youth. I could talk about that for a lot longer than you guys have. But adults as well are not well. 76% of people are living paycheck to paycheck. That matters. That, if you can't sleep at night because you think your electric's going to turn off, me throwing some medicine at it is not going to solve the problem. But what we're seeing is people showing up to primary care desperate for help. And what we're also seeing, and one thing that I think is not included in a lot of this research, is primary care burnout. So I'm sure maybe some head nods if you guys have heard of primary care physicians or primary care providers suffering from like record high burnout and a lot of turnover in the primary care space. That is because they're being forced to deal with problems that are way out of their scope. They're not psychiatrists. They didn't train to do what I do, but patients are showing up desperate for help and they don't have the resources unless, they practice someplace like Sterling Health or places that have integrated behavioral health care. They are basically saying, gee, I'm sorry. Maybe if I throw this medicine at you, you'll feel better. Come back in a month and we'll see. And as it should come as no surprise, that's not terribly effective treatment. So what I like about integrated healthcare, but specifically the collaborative care model, which is the one that has been the most well studied, has the most evidence backing it. It does, we know that it reduces costs. That's always something I know you guys like to hear. It also reduces the stigma associated with behavioral health care. If people have to go to a separate building, a separate facility to go see a therapist or a psychiatrist, they're less likely to utilize it. And it also really improves PCP burnout. They really, that's one of the major attracting factors for primary care providers to come work at Sterling Health is they love knowing that they have that built-in backup. So when they're forced to deal with something that's technically out of their scope, they can say, whoa, hold on. This sounds really bad. I'm so sorry you're feeling this way. Let me have you go talk to Rebecca. Let me have you talk to somebody this is in their wheelhouse, and they can get you started on the right path. So really what collaborative care allows you to do is a lot more effectively and expertly triage patients. We have, a wide range of acuity. We have people showing up who are flirily psychotic. Their family members can't get them to sleep. They've been awake for 4 days. They're talking nonsense. That happens, not irregularly. And then we also have people who just kind of have indolently been going along, have depressive symptoms that are affecting their functioning, but not to the extent that they sought psychiatric care. That's a huge range in what that patient, the patient who's just suffering some minimal depression probably could just meet with PCP, maybe a behavioral health consultant 1 or 2 times, be on their way. Somebody who's florally psychotic obviously needs to come see me pretty quick. But if we don't have the tools in place to triage, and if we're not being reimbursed for that, then basically patients everyone gets shuttled to the highest level of care and it's unnecessary, it's wasteful. Trying to keep it brief.
I appreciate it.
What's your number? I might need to
I charge a lot. No, just kidding.
So we're happy to entertain any questions at this point.